Hello, I'm Professor Sims, and in this video I will discuss the appendicular skeleton. This is the sixth in a series of 10 lessons held as part of my Anatomy and Physiology 1 course. If you're a student currently enrolled in this course, please consult the syllabus and course Moodle site for assignments, quizzes, due dates, and other course information. In this unit, we will learn about the appendicular skeleton, including the bones of the pectoral and pelvic girdles, the bones of the upper limb, including the bones of the arm, forearm, wrist, and hand, the features of the pelvis, and how these features differ between adult males and females. We'll describe the bones of the lower limb, including the bones of the thigh, leg, ankle, and foot. And finally, we'll talk about the embryonic formation and growth of the limb bones. Recall that we discussed the bones of the axial skeleton, that is the skull, vertebrae, and ribs, in the last lesson. This time we're going to be learning about the bones of the arms, legs, shoulders, collarbone, pelvis, all of the bones that make up the appendicular skeleton. The appendicular skeleton helps support the axial skeleton, and it also facilitates body and limb movements. The shoulder girdle, also known as the pectoral girdle, consists of two main bones, the clavicle, or the collarbone, and the scapula, or shoulder blade. These bones connect your arms to your body, providing places for muscles to attach, and helping you move your arms and shoulders in different directions. What's interesting is that each side of the shoulder girdle can move independently, giving you a lot of flexibility. The scapula is a flat triangular bone located in your upper back. It connects with your upper arm bone, allowing your shoulder joint to move freely. On the other hand, the clavicle has a shape like the letter S. It connects to your breastbone at one end. It also connects to the scapula, helping your shoulder joint work smoothly. The clavicle, also known again as the collarbone, has several important jobs in keeping your shoulder stable and working properly. It acts like a support beam, helping to hold the shoulder blade in place and positioning the shoulder joint correctly. Think of it as a strut that supports your shoulder from the side and helps distribute the weight and stress from your arm across your upper body. It also protects the nerves and blood vessels running underneath it. The clavicle is divided into three parts: the end that is closest to your sternum or your breastbone, the end that is next to your shoulder, and the part in between. It can look different in males and females, with variations in size and shape reflecting biological differences. Figure 8.3 shows the location of the clavicle within the pectoral girdle, where the shoulder meets the chest. This is where the pectoral girdle is situated. From here you can see a bone that extends horizontally from the sternum toward the shoulder. This is the medial end of the clavicle, where it articulates with the sternum. Near the outer end of the clavicle, the acromion process of the scapula forms a joint with the clavicle. Observe the slight curvature of the clavicle's bone in this S shape. The scapula, also known as the shoulder blade, is a flat triangular bone situated in the backside of the shoulder. It's primarily used as a significant attachment site for numerous muscles involved in the intricate movements of the arm and shoulder. Figure 8.4 shows the isolated scapula from its anterior side on the left and its posterior side on the right. Distinct anatomical landmarks of the scapula include superior, medial, and lateral borders, along with a prominent spine that divides the posterior surface into supraspinous and infraspinous fossae. The glenoid cavity found on the lateral aspect of the scapula forms the glenohumeral joint with the humerus. The acromion and coracoid process are attachment sites for various muscles and ligaments. Let's discuss these in just a little bit more detail. The coracoid process sticks out in the front of the scapula and gives muscles and ligaments a place to attach, and this helps you to move your arms and shoulders smoothly. On the collarbone, on the scapula, is the acromion process, which connects to the collarbone and adds more stability to your shoulder. There's also a ridge called the spine that divides the scapula into two parts, the supraspinous fossae above and the infraspinous fossae below. and these areas are where muscles attach to help lift and rotate your arm. The glenoid fossa is a shallow area where your upper arm bone fits, and this allows your arm to move in many directions. The scapula also has a smooth area called the subscapular fossa on the front, which helps muscles move your arm. At the top of the scapula is the suprascapular notch, which lets a nerve pass through to reach your shoulder muscles. Finally, there's two borders on the side of the scapula. The one closer to your spine is called the vertebral border, and the one near your armpit is the axillary border. At the bottom of the scapula is the inferior angle, and at the top is the superior angle. And all of these parts work together to help you move your arms and shoulders comfortably.
The appendicular skeleton includes all of the limb bones, plus the bones that unite each limb with the axial skeleton. The bones that attach each upper limb to the axial skeleton form the pectoral girdle. This consists of two bones, the scapula and the clavicle. The clavicle, or collarbone, is an S-shaped bone located on the anterior side of the shoulder. It is attached on its medial end to the sternum of the thoracic cage. The lateral end of the clavicle articulates or joins with the scapula just above the shoulder joint. The scapula, or shoulder blade, lies on the posterior aspect of the shoulder. It is supported by the clavicle and articulates with the humerus to form the shoulder joint. The scapula is a flat, triangular-shaped bone with a prominent ridge running across its posterior surface. This ridge extends out laterally, where it forms the bony tip of the shoulder and joins with the lateral end of the clavicle. The clavicle of each pectoral girdle is anchored to the axial skeleton by a single, highly mobile joint. This allows for the extensive mobility of the entire pectoral girdle, which in turn enhances movements of the shoulder and upper limb. The clavicle has three regions: the medial end, the lateral end, and the shaft. The medial end, known as the sternal end of the clavicle, has a triangular shape and articulates with the manubrium portion of the sternum. This forms the sternoclavicular joint, which is the only bony articulation between the pectoral girdle of the upper limb and the axial skeleton. This joint allows considerable mobility, enabling the clavicle and scapula to move upward and downward and anteriorly and posteriorly during shoulder movements. The lateral or acromial end of the clavicle articulates with the acromion process of the scapula. This is the portion of the scapula that forms the bony tip of the shoulder. The scapula plays an important role in anchoring the upper limb to the body. The scapula has several important landmarks. The three margins or borders of the scapula are named for their positions within the body. These are the superior border of the scapula, the medial border of the scapula, and the lateral border of the scapula. The suprascapular notch is located lateral to the midpoint of the superior border. The corners of the triangular scapula at either end of the medial border are the superior angle of the scapula and the inferior angle of the scapula. The inferior angle of the scapula is the most inferior portion of the scapula and is particularly important because it serves as attachment points for several powerful muscles involved in shoulder and upper limb movements. The remaining corner of the scapula between the superior and lateral borders is the location of the glenoid cavity or glenoid fossa. This shallow depression articulates with the humerus bone of the arm to form the glenohumeral joint. The small bony bumps located immediately above and below the glenoid cavity are the supraglenoid tubercle and the infraglenoid tubercle. These provide attachments for the muscles of the arm. The scapula also has two prominent projections. One is the hook-like coracoid process. At the shoulder joint, the coracoid process is located inferior to the lateral end of the clavicle. It is anchored to the clavicle by a strong ligament and serves as attachment sites for muscles of the anterior chest and arm. On the posterior aspect, the spine of the scapula is a long prominent ridge that runs across the upper portion. Extending laterally from the spine is a flattened and expanded region called the acromial process. The acromion, or acromial process, forms the bony tip of the superior shoulder region and articulates with the lateral end of the clavicle, forming a acromioclavicular joint. Together, the clavicle, acromion, and spine of the scapula form a V-shaped bony line that provides attachment sites for the neck and back muscles acting on the shoulder, as well as muscles that pass across the shoulder joint and act on the arm. The scapula has three depressions, each of which is called a fossa. Two of these are found on the posterior scapula, above and below the scapular spine. Superior to the spine is the narrow supraspinous fossa, and inferior to the spine is the broad infraspinous fossa. The deep anterior surface of the scapula forms the broad subscapular fossa. All of these fossae provide large surface areas for the attachment of muscles that cross the shoulder joint and act on the humerus.
The upper limb can be divided into three main parts: the arm, forearm, and hand. The arm is the section between the shoulder and elbow joints. The forearm extends from the elbow to the wrist. The hand is located beyond the wrist. In total, each upper limb contains 30 bones. The upper arm has one bone called the humerus. In the forearm, there's two bones, the ulna on the inner side and the radius on the outer side. At the base of the hand, there are 8 small carpal bones, followed by 5 metacarpal bones on the palm. And then there's 14 phalanx bones that make up the fingers and the thumb. These bones all work together to support and enable movements of the upper limb. The humerus is the bone in the upper arm, and it's got several important features. At the top, the head of the humerus connects with the glenoid cavity of the scapula, forming the glenohumeral joint, which allows for arm movement. On the humerus, you'll find the greater and lesser tubercles, which are spots where muscles attach, and then between those tubercles is the intertubercular groove, which lets the biceps brachii tendon pass through. Near the middle of the bone is the deltoid tuberosity, where the deltoid muscle attaches. At the bottom, the distal end of the humerus connects with the ulna and radius bones to form the elbow joint. The ulna is the bone on the inner side of the forearm. At the top, the trochlear notch of the ulna connects with the humerus, forming part of the elbow joint. Some key features of the ulna include the coronoid process, ulnar tuberosity, and the radial notch. The coronoid process helps stabilize the elbow joint. The ulnar tuberosity is a point where muscles attach, and the olecraneum process forms the bony tip of the elbow. Along the length of the ulna is the interosseous border, which provides attachment for a membrane. And then the head of the ulna connects with the radius bone, allowing for rotation of the forearm. The radius is the bone that's on the thumb side of the forearm. Its head connects with the capitulum of the humerus and the radial notch of the ulna, forming part of the elbow joint. A bump called the radial tuberosity provides a spot for muscles to attach, aiding in forearm movement. And then along the shaft of the bone runs the interosseous border, where a membrane attaches. At the bottom, the distal end of the radius connects with the carpal bone, forming the wrist joint. The carrying angle refers to a slight bend, about 5 to 15 degrees, that naturally occurs in the forearm when the arm is in the anatomical position. This angle allows for freedom of movement without the forearm hitting the hip when you swing your arms. It's a subtle but important feature that helps with everyday activities like walking and carrying objects. This is figure 8.5 on the left. It shows the humerus, which is the single bone of the upper arm region. The humerus articulates with the radius and ulna bones of the forearm, and that's where you see the elbow joint here. Figure 8.6 is on the right here, and this is showing the ulna and radius. The ulna is located on the medial side of the forearm, and the radius is on the lateral side. And these bones are attached to each other by interosseous membranes. And you can see on the top here is where the elbow joint connects. The hand's skeletal structure comprises 3 main sets of bones: carpal bones, metacarpal bones, and phalanx bones. The carpal bones, 8 in total, are arranged in 2 rows. In the proximal row, from lateral to medial, they include the scaphoid, lunate, triquetrum, and pisiform. In the distal row, also from the lateral to medial, they consist of the trapezium, trapezoid, capitate, and hamate. These bones are crucial for wrist movement and stability. Encasing these bones is the flexor retinaculum, which forms the carpal tunnel, providing a passageway for nerves and tendons. The metacarpal bones are elongated structures numbering 5 in total, and they extend from the wrist to the base of the fingers, forming the palm of the hand. They articulate with the distal carpal bones on one end and the proximal phalanges on the other, facilitating movement and support for the fingers. Notably, the first metacarpal bone on the thumb is distinct and separate from the others, and this enhances the thumb's range of motion and dexterity. The phalanx bones are the finger and thumb bones, totaling 14. The thumb comprises a proximal and distal phalanx, while the other digits 2 to 5, each have a proximal, middle, and distal phalanx, and between these bones lie the interphalangeal joints, facilitating flexion and extension movements. This hierarchical arrangement of bones in the hand is essential for its intricate movements and for its functionality. Figure 8.7 shows the skeletal structure of the hand. The 8 carpal bones form the base of the hand here, and they're arranged into proximal and distal rows of 4 bones each. The metacarpal bones form the palms of the hands, and the thumbs and the fingers are the phalanx bones.
This is a video about the bones of the upper limb. Here they are represented in a fully articulated skeleton. They include the scapula, the humerus, the clavicle, as well as the radius and the ulna. And now let's take a closer look at each bone.
We have the pectoral girdle, which consists of the clavicle and the scapula. We have the humerus, and then we have the ulna and the radius. If we take a closer look at the clavicle, this is the only point of articulation with the axial skeleton. And if we bring the sternum in, we can see that the clavicle articulates with a manubrium at the sternoclavicular joint. The sternal end of the clavicle is round in shape, and that is medial. The lateral part of the clavicle is more flat, and that articulates with the acromion of the scapula at the acromioclavicular joint. We also have the conoid tubercle, and the conoid tubercle faces inferior and posterior. This is the anterior view of the scapula. We have the subscapular fossa here. Laterally, we have the glenoid fossa, which articulates with the humerus. And above the glenoid fossa, we have the supraglenoidal tubercle. And below the glenoid fossa, we have the infraglenoidal tubercle. We have the coracoid process here. And if we turn it over to take a posterior view, we have the spine of the scapula here and the acromion process here. Below the spine of the scapula, we have the infraspinous fossa, and above the spine of the scapula, we have the supraspinous fossa. The glenoid fossa of the scapula articulates with the head of the humerus. Laterally, we have the greater tubercle, and anterior, we have the lesser tubercle. In between the two tubercles, we have the intertubercular groove. A little ways down the shaft, we have the deltoid tuberosity, which is where the deltoid inserts. And on the distal end, we have our condyles. The medial one is the trochlea, which means pulley, and this articulates with the trochlear notch on the ulna. And laterally, we have the capitulum, and this articulates with the head of the radius. On each side of the condyles, we have an epicondyle. So this is the medial epicondyle, and this is the lateral epicondyle. On the anterior side, we have a fossa here, which is called the coronoid fossa, where the coronoid process of the ulna fits in during flexion. If we turn the humerus over, we can see we have the olecranon fossa on the posterior portion of the bone, where the olecranon process of the ulna fits during extension. The first bone we'll look at of the forearm is the ulna, and the ulna is medial. This here is called the trochlear notch, which articulates with the trochlea on the humerus. This is the olecranon process, which fits into the olecranon fossa during extension, and the coronoid process fits into the coronoid fossa during flexion. On the lateral side of the ulna, we have the radial notch, which articulates with the head of the radius. On the distal end of the ulna, we have the stylus process, which is medial. And that brings us to the radius. Here we have the head of the radius, which articulates with the capitulum on the humerus and the radial notch on the ulna. We also have the radial tuberosity, which must be anterior. On the distal portion, we have the ulnar notch, which is medial, and we have the styloid process.
Fractures and injuries affecting the upper limb are frequently observed, often resulting from falls or from direct impacts. Among the bones susceptible to fractures, the humerus, radius, and scaphoid are particularly prone to injury. For instance, older individuals commonly experience a Cole's fracture of the distal radius, and this is characterized by a break near the wrist. Fractures involving the scaphoid bone can be especially problematic due to their tendency for slow healing and potential complications with healing. Inflammation within the narrow carpal tunnel can lead to carpal tunnel syndrome, and this syndrome causes discomfort and impaired hand function. Additionally, fractures of the humerus may pose added risk due to their proximity to major nerves, and it can potentially lead to nerve damage and further complications. Falls or direct blows can result in fractures of the surgical neck or shaft of the humerus. Trauma from a high-velocity accident, such as a car collision, or direct impact to the elbow due to a fall, are common causes of distal humerus fractures. A Cole's fracture of the distal radius is the most common forearm fracture, characterized by a break in the distal end of the radius bone, often resulting from a fall on an outstretched hand. It typically causes the wrist to bend backward and results in a characteristic dinner fork deformity. The pelvic girdle, composed of the hip bone or coxal bone, forms the attachment point for each of the lower limbs. Each hip bone is securely connected to the axial skeleton through the sacrum, and the right and left hip bones converge anteriorly, attaching to each other. The collective structure, consisting of two hip bones, sacrum, and coccyx, is referred to the bony pelvis. In terms of characteristics, the pelvis bones, unlike the highly mobile bones of the pectoral girdle, are strongly united to create a stable and largely immobile weight-bearing structure. This immobility is vital, allowing the easy transfer of body weight laterally from the vertebral column to the lower limbs. The stability of the pelvis provides a robust foundation for the upper body, which rests on the mobile lower limbs. Figure 8.12 shows the location of the pelvic girdle, and it illustrates how it is formed by a single large hip bone. The hip bone attaches to the lower limb and to the axial skeleton through its articulation with the sacrum. The right and left hip bones plus the sacrum and coccyx together form the pelvis. The three fused bones of the hip are named the ilium, the ischium, and the pubis. The ilium forms the fan-like superior region of the hip, joined to the sacrum at the sacroiliac joint. The prominent arching margin, known as the iliac crest, includes an attachment point called iliac spines. Notably, the anterior superior iliac spine serves as an anchor for thigh muscles, while the posterior superior iliac spine supports ligaments of the sacroiliac joint. On the anteromedial surface lies the iliac fossa, a shallow depression, and then moving into the posterior margin, the greater sciatic notch, which is a large U-shaped indention, provides passage for important structures. The ischium, located in the the posterior-inferior hip region, offers support during sitting. Its roughened area, the ischial tuberosity, bears weight when seated, while the ischial ramus and narrow segment extends from it. Above the tuberosity lies the lesser sciatic notch, and separating the greater and lesser sciatic notches is the ischial spine, which is a distinct bony projection. The hip's anterior portion comprises the pubis, which forms the pubic symphysis when united with the opposite hip bone. Within the pubic bone, the pubic body, an enlarged medial portion, includes distinct features such as the pubic tubercle and ramus. This ramus further divides into superior pubic ramus, connecting to the ilium, and the inferior pubic ramus, extending downward to contribute to the ischiopubic ramus formation. At the junction of the pubic bodies lies the pubic symphysis, a joint that forms the subpubic angle. The pelvic cavity is divided into two main regions: the greater pelvis, also known as the false pelvis, which is broad and superior, associated with the abdominal cavity. And then you have the lesser pelvis, or true pelvis, which is narrow, rounded, and contains pelvic organs. Understanding these structures helps to comprehend the pelvic anatomy and its functional divisions. Figure 8.13 shows these three regions of the adult hip bone: the large fan-shaped ilium, the posterior inferior ischium, the anteromedial pubis, and other features like the iliac crest, the ischial tuberosity, and pubic symphysis. These landmarks serve as attachment points for muscles, ligaments, and tendons, and they play essential roles in hip stability, motility, and biomechanics. If you compare the male and female pelvis, you'll see there are distinct adaptations to accommodate differing anatomical and physiological needs. The male pelvis is tailored for a heavier build and stronger muscles, reflecting its role in supporting greater body mass and physical exertion. In contrast, the female pelvis is wider, particularly evident in the greater sciatic notch width, and this is to facilitate childbirth by providing more space for the passage of the infant's head. Additionally, variations exist in the sacrum width, shape, and overall pelvic cavity dimensions, contributing to individual differences in pelvic morphology. These adaptations underscore the intricate interplay between skeletal structure and reproductive function in both sexes. Table 8.1 further outlines the key differences between the male and female pelvis in terms of weight, subpubic angle, so that is this angle here, inlet, lesser cavity, and outlet shape as well. The lower limb, much like the upper limb, can be divided into three primary regions. The thigh, situated between the hip and knee joints, transitions into the leg, which extends from the knee joint to the ankle joint, and then you have the foot positioned distal to the ankle. This region comprises a total of 30 bones, including the femur, patella, tibia, fibula, tarsal bones, metatarsal bones, and phalanges. Beginning with the femur, also known as the thigh bone, this bone stands out as the longest and sturdiest bone in the body, contributing approximately 1/4 of an individual's total height. Its proximal head articulates with the hip bone's acetabulum, forming the hip joint, while the elongated shaft features prominent structures like the greater and lesser trochanters, intertrochanteric line, and intertrochanteric crest. Moving distally, the femur forms medial and lateral condyles and epicondyles, which are important for articulation within the knee joint. The patella, commonly referred to as the kneecap, serves as the largest sesamoid bone embedded within the quadriceps femoris tendon. Its primary function is to shield the muscle tendon from abrasion against the femur during joint movements, thus enhancing the leverage of the quadriceps femoris muscle across the knee. The tibia, located on the inner side of the leg, serves as the primary weight-bearing bone. At its proximal end, it features medial and lateral condyles that articulate with the femur, forming the knee joint. The tibial tuberosity acts as the attachment point for the patellar tendon, while at the distal end, there's the medial malleolus, a prominent bony projection that forms part of the ankle joint. The fibula is a slender bone situated on the leg's outer side, and it doesn't bear weight, but it is vital for muscle attachment. It has distinctive structures such as the head, shaft, and lateral malleolus, which contributes to the formation of the lateral ankle joint. Figures 8.16 and 8.18 provide an anatomical view of the bones of the leg. The femur is the single bone of the thigh region. It articulates superiorly with the hip bone at the hip joint and inferiorly with the tibia at the knee joint. The patella only articulates with the distal end of the femur. In the lower leg or the calf region, the tibia is the larger weight-bearing bone located on the medial side of the leg. The fibula is the slender bone of the lateral side of the leg, and it does not bear weight.
So this is a coxal bone which forms part of our pelvic girdle. There's three fused bones which make up a coxal bone. The top portion or superior portion is called the ilium. The inferior posterior portion or down and towards the back is called the ischium. And the anterior portion, or the bit facing towards the front, is called the pubis. Now the borders for these three fused bones form somewhere around here. So above my fingers, or superior to my fingers there, is called the ilium. Beneath and towards the back is the ischium, and towards the front and beneath is called the pubis. So the borderline between the pubis and the ischium forms halfway along this bridge or ramus. Now there's another couple of distinguishing features on the coxal bone which help us determine which side the coxal bone is. The first is we've got this spherical socket called the acetabulum. And this is the socket for the ball and socket joint of the hip where the femur or the head of the femur attaches into. So we know the femur attaches to the lateral side. We also have this rough or articular surface edge here for the sacrum. So the actual sacrum attaches to a coxal bone like so. Now if we've got the head of the femur on the lateral side and we've got the sacrum edge on the medial side forming the sacroiliac joint, then this must be a right coxal bone. So this is a femur. There's a couple of distinguishing features on the femur which help us determine that it is indeed the femur. The firstly is it's got this spherical head on top of the narrow neck. Now, the spherical head indicates that it forms part of a ball and socket joint. There is only two ball and socket joints, one being the hip, so it certainly narrows down which bone this could actually be. The other things on the femur which help us determine which bone it is, it's got these two round spherical objects on the lower end or the inferior end. They're called the condyles of the femur. We've got a medial condyle and we've got a lateral condyle. Two condyles sitting next to each other help us also determine what kind of joint forms at the knee, which is a bicondyloid joint, and that's how it gets its name. Now you'll also notice that the femur's got this natural posterior curve to it. That also helps us determine which femur this is, because if the ball and socket joint is on the medial side of the femur and the natural curve always goes posterior or towards the back, then this must be a right femur. So this is a tibia. There's a couple of distinguishing features on the tibia which help me determine that it is indeed the tibia. Firstly, we've got these two grooves at the top, or condyles on the tibia. These condyles are matching the femoral condyles, which help determine that bicondyloid joint of the knee. On the inferior end of the tibia, we've got this one lump which protrudes further than the other side. This is called the medial malleolus. We know that the medial malleolus is on the medial side of the leg, and if you feel down towards your ankles, this is the lump that you can feel protruding out that medial side of your ankle. The lateral malleolus forms part of the fibula, so it cannot be seen in this description. Now, you'll also notice that the tibia itself has this posterior curve to it also. Now, if we know the tibia is the medial bone in your lower leg, and the medial malleolus is on the medial side of the medial bone, then this must be a right tibia. So this is the fibula. The fibula is more difficult to determine than some of the other bones because there's less distinguishing features on it, but it does have a couple. Firstly, it's got the head of the fibula. And you'll notice here the head of the fibula, there's a lower side. The lower side of the head of the fibula points anteriorly. So that's towards the front. Now, on the inferior side of the fibula, we have what's called a lateral malleolus. Now, if you feel down to your ankle bones that lump in the lateral side of your ankle, that's what we're indeed feeling, is the lateral malleolus. On the medial side of the fibula, we've got a shiny surface. That shiny surface is an articular surface which joins to the tibia. So if this is the lateral bone in your lower leg, and the articular surface must adjoin the tibia, which is the medial bone, then this must point or face inwards. We also know that the head, the lower portion of the head, faces anteriorly, so this must be a right fibula.
The posterior half of the foot is comprised of several tarsal bones, including the talus, calcaneus, cuboid, and cuneiform bones. These bones collectively contribute to the formation of both the transverse and longitudinal arches of the foot, which play central roles in providing structural support and facilitating weight distribution during locomotion. The anterior half of the foot consists of the metatarsal bones, numbered 1 through 5, and the phalanges, which make up the toes. Each toe comprises proximal, middle, and distal phalanges. Additionally, the foot possesses 3 arches, the transverse arch, and the medial and lateral longitudinal arches, and these all aid in shock absorption, energy storage, and efficiency of weight distribution, which ensures stability and flexibility during various activities. Figure 8.19 shows the 3 regions of the foot. The posterior foot is formed by the 7 tarsal bones. The midfoot has the 5 metatarsal bones. The toes contain the phalanges. And any imbalance or abnormality in these structures, such as in conditions like runner's knee or plantar fasciitis, can lead to discomfort or altered biomechanics, emphasizing the intricate interplay of bones and joints in the lower limb's functionality.
The foot is a separate organ that is at the terminal part of the human body and many other vertebrates. It helps us to stand and also to move around. That is, it allows locomotion. The foot and the ankle together consist of 26 bones and 33 joints, apart from the many other ligaments, tendons, and muscles. This duo, that is, the foot and the ankle, form a complex mechanical structure that has 5 toes, which helps complete the functionalities of the foot. That is, helps us to stand and move both forward and backwards. The skeleton structure of the foot starts at the ankle bone, which acts like a junction where the 2 bones of the lower leg meet and help in the formation of a stable structure that holds the foot in a firmer position. The 2 bones making up the back part of the foot are known as heel bones. Calcaneus, commonly known as the heel bone, is actually a large bone that aids in the foundation of the rear part of the foot. The calcaneus connects with both the talus and the cuboid bones. The joint formed between the talus and the calcaneus is known as the subtalar joint, which helps in the normal functioning of the foot. It allows the foot to move from side to side. The tarsal bones are a set of 5 bones that coordinate together as a group, and the way they fit together is kind of unique, especially the way when they lock and unlock themselves to provide movement of the foot in different directions. The ankle joint is a pivotal point for movement of the foot. It allows the foot to bend up and down.
The appendicular skeleton originates embryologically from mesenchyme, which again is a versatile embryonic tissue capable of differentiating into various other tissues, including bone and muscle. Mesenchyme plays a pivotal role in giving rise to the bones of both the upper and lower limbs, as well as the pectoral and pelvic girdles. The development of limbs follows a timeline, commencing at around the 4th embryonic week. The upper limbs make their appearance before the lower limbs, with a slight lag of a few days. Limbs undergo a growth process as limb buds, initially manifesting as small little bulges on the embryo's lateral side, and these limb buds consist of mesenchyme covered by ectoderm, and their elongation is stimulated by the apical ectodermal ridge, directing growth along a proximal to distal axis. The formation of hands and feet unfolds during the 6th week, as the distal ends of the limb buds flatten into paddle shapes, and these regions subsequently become hands or feet with distal wrist or ankle constriction. Tissue within the limbs experiences controlled cell death, resulting in the separation of the fingers and toes within these little paddle-shaped appendages. During the 7th week, a rotational shift occurs where the upper limb rotates laterally by 90 degrees, positioning the palm anteriorly and the thumb laterally. And then in the lower limb, we have a 90-degree medial rotation, which brings the big toe to the medial side of the foot. Ossification, which is the process of bone formation, is a critical aspect of the appendicular development. Girdle and limb bones, excluding the clavicle, undergo endochondral ossification, initiated by a primary ossification center in the diaphysis around the 12th week. Secondary ossification centers emerge in epiphysis after birth, and the epiphyseal plate located between the diaphysis and each epiphysis is fundamental for bone lengthening. The femur's ossification timeline provides insights into its development starting at the end of the 7th week and progressing with sequential fusion of trochanters and epiphyseal plates. Clubfoot is an example of a congenital deformity affecting the lower limb. It occurs at a frequency of about 1 in 1,000 births, and it involves a sharp inward twist of the foot and ankle, resembling the head of a golf club. While its exact cause is unknown, genetic factors and maternal smoking during pregnancy are implicated as causes. Fortunately, 90% of clubfoot cases find successful treatment without surgery, utilizing corrective casting technique initiated within the first 2 weeks after birth. Monitoring adherence to postoperative instructions and the use of braces and special shoes minimize the risk of relapse. Noteworthy individuals that have been born with clubfoot include Dudley Moore, Damon Wayans, Troy Aikman, Christy Yamaguchi, Maya Hamm, and Charles Woodson. All of these people have very healthy and successful lives despite having this congenital deformity. Thank you guys for watching. Don't forget to do the reading. Check the description